Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Janus kinases, nothing but JAK. What do you get from this word kinase? It is an enzyme which transfers phosphate group, that is nothing but phosphorylation. These Janus kinases are a family of non-receptor tyrosine kinases. What do you mean by this word non-receptor? Tyrosine kinases, by the word kinase, you got it will phosphorylate. It has two types. One is receptor tyrosine kinase, another one is non-receptor tyrosine kinase. Receptor tyrosine kinases have intrinsic kinase activity and receptor activity also. What kind of receptor it is? It is receptor for growth factors. What and all growth factors we know, we'll revise. Epidermal growth factor, fibroblast growth factor, platelet derived growth factor, vascular endothelial growth factor, stem cell factor, nothing but c-KIT. These are all examples of receptor tyrosine kinases which have both receptor activity to identify growth factors and kinase activity to undergo phosphorylation. Here, if our drug blocks receptor tyrosine kinase, c-KIT and platelet derived growth factor receptor, it is imatinib. If it blocks non-receptor tyrosine kinases, which doesn't have receptor activity, it won't identify any stimulus. It will have only kinase activity. That is nothing but our JAK inhibitors. JAK inhibitor is a family of 4 members. JAK 1, 2, 3 and tyrosine kinase 2. These members will form dimers with each other according to stimuli. When they get activated, clear, Janus kinases are non-receptor tyrosine kinases. Only they have kinase activity. If they have receptor activity also, those will go under growth factor receptors. And the drug blocking them is imatinib. Here, drug blocking non-receptor tyrosine kinases, JAKs, are Tofacitinib. What is the mechanism of action? Now, I told these are non-receptor. They don't have any receptor activity. So, they are linked with cytokine receptor. So, these cytokine receptors will respond to cytokines. Here you can see interferon gamma. Our cytokine receptor is identifying it and then stimulating JAK receptor. JAK receptor is having kinase activity. So, it is phosphorylating STAT and leading to STAT phosphorylation and forming STAT dimer. First cytokine receptor is stimulated, then JAK is activated and they form dimer. Here you can see JAK 1 and 2 are forming dimer. Then it phosphorylates STAT and then STAT forms dimer. Then STAT will go to nucleus and leads to release of pro-inflammatory cytokines. Interferon gamma, interleukin 12, 23, according to which cytokine it is responding, it will release that specific pro-inflammatory cytokines. What we are doing? We are giving JAK inhibitor. It will inhibit JAK and stops this pathway. What is this pathway called? JAK-STAT pathway, leading to anti-inflammatory effect. That is nothing but mechanism of action of our JAK inhibitors. JAK inhibitors also have immunomodulatory effect. They are disease modifying anti-rheumatoid drugs. They belong to a type of that class, mainly FDA approved for rheumatoid arthritis only. Here you can see in one line mechanism of action. These tyrosine kinases respond to cytokines via cytokine receptor because these are not receptors. Then these tyrosine kinases will phosphorylate STAT, activate STAT, STAT will go to nucleus, releases pro-inflammatory cytokines. This entire JAK-STAT pathway we are going to block with what drugs we will see now. They are classified into two generations. First generation is non-selective. You can see clearly JAK1 is also there, JAK3 is also there. It is not selective to specific family member of JAK inhibitor. That is Tofacitinib. FDA approved uses are rheumatoid arthritis. I already told you these are all a type of disease modifying anti-rheumatoid drugs, immunomodulators, and their main mechanism of action is anti-inflammatory, blocking JAK-STAT pathway. Psoriatic arthritis, ulcerative colitis. These are all FDA approved uses of Tofacitinib. Next, baricitinib, JAK1/2 inhibitor approved for rheumatoid arthritis, FDA approval. Next, ruxolitinib, olitinib, polycythemia. Remember like this, JAK1/2 same like baricitinib. Myelofibrosis. Then delgocitinib. I wrote here topical because it has only topical formulation got approved and available in USA. It is pan-JAK inhibitor. Inhibits all the 4 family members of JAK 1, 2, 3 and tyrosine kinase 2. Approved for chronic hand eczema. Now second generation, these are selective JAK inhibitors which will target only selectively one JAK family member. Here see it is targeting JAK1. Here it is targeting tyrosine kinase 2. Deucravacitinib, upadacitinib, abrocitinib. A for abrocitinib approved for atopic dermatitis. Upadacitinib approved for all atopic dermatitis, rheumatoid arthritis, ulcerative colitis. No need to go into details. Our topic proper will enter into details of Tofacitinib. Already we know FDA approved uses arthritis, rheumatoid arthritis, psoriatic arthritis, ulcerative colitis. 3 FDA approved uses finish. Now we will see off-label uses of Tofacitinib. I can just write off-label uses, but I am clearly mentioning Tofacitinib each and every subheading also, because we can make mnemonics at each and every subtopic level also for easy remembrance, because we will be having Tofacitinib word in question paper. So seeing that without getting tensed or nervous, we will copy paste as it is with every subheading. Then we can enter into some points about that subheading. Now off-label uses of Tofacitinib. With this A, we can write 3 off-label uses: alopecia areata, atopic dermatitis, chronic actinic dermatitis. Psoriasis vitiligo. Already it got approved by FDA for psoriatic arthritis. Now here psoriasis vitiligo, off-label uses. Next, connective tissue disease, dermatomyositis, systemic sclerosis, DLE, cutaneous T-cell lymphoma, idiopathic erythema multiforme, hypereosinophilic syndrome. If you get many words which are tough to remember, just pause the video, by heart it, and then move to next slide. Why we are using in psoriasis? Psoriatic skin has upregulated JAK-STAT signaling. So we are blocking this JAK-STAT pathway itself. Coming to its formulations, available in ointment 2%, oral solution, and mainly tablets, 5 mg, 10 mg dosages. It has good oral absorption, good bioavailability of 70%, reaches peak within half an hour, T-half of 3 hours. These are all you have to by heart, no other option. Metabolized in liver by CYP3A4 enzyme to inactive metabolites. Some drugs will have active metabolites. Here Tofacitinib, if it got metabolized, that's it. It will become inactive metabolite and excreted via feces, mainly 70%. Unchanged in urine, 30%. It has very less drug interactions. Mainly it interacts with triazoles like fluconazole, which will increase Tofacitinib levels, and enzyme inducers will reduce Tofacitinib. If enzyme induces this CYP3A4 enzyme, and this Tofacitinib will automatically get converted to inactive metabolites, so its level will reduce and therapeutic effect will also reduce. It is category C drug. So contraindicated in pregnancy. Coming to adverse effects, based on these adverse effects, you have to write what investigations you will do, what and all you will monitor, what are all contraindications. No need to mention separately. In exam, you have to put the subheadings and write yourself. Now, coming to its adverse effects, mainly we are reducing pro-inflammatory cytokines, and we are also, it is also doing immunomodulation. So if immunity reduces, there will be more chance of getting infections, upper respiratory tract infections, reactivation of TB, herpes, and other opportunistic infections. So before starting therapy, we have to consider prophylactic pre-treatment with zoster vaccine. And if we are using any immunomodulator, already immunity is less, so we have to avoid live vaccines 3 months prior to treatment and 3 months post treatment. If we consider giving live vaccine, it should be given 3 months before or 3 months after the therapy. During therapy, body will be having less immunity. So avoid live vaccines while on Tofacitinib. So based on that, what and all tests we will do? We will check first there is any active TB or latent TB by X-rays, MAN2 tests, and we will check hepatitis B, hepatitis C. These will also get reactivated prior starting Tofacitinib. Next, adverse effect, malignancy, most commonly non-melanoma skin cancer. Melanomas also can occur, solid organ malignancies, Epstein-Barr virus associated lymphomas. When given with other immunosuppressants, it is already suppressing immunity. If you give other immunosuppressants also, further increasing risk for Epstein-Barr virus associated lymphomas and other malignancies. Mainly in post-transplantation patients, we will be giving immunosuppressants. So more chance of malignancies. Hematological adverse effects of Tofacitinib: lymphocytopenia, neutropenia, anemia. For anemia, what we will see? Hemoglobin. If it is less than 9, stop the drug. For neutropenia, absolute neutrophil count less than 500 cells per mm cube, stop the drug. Lymphocytopenia, total leukocyte count less than 500 cells per mm cube, stop the drug. Before starting the drug also, if these parameters are deranged, it's a absolute contraindication. Don't start the drug at all. Next, pulmonary complications. Dyspnea. Why? Pulmonary edema embolism, interstitial lung disease, chronic obstructive pulmonary disease. Metabolic derangements like increased total cholesterol, triglycerides, LDL, low density lipoproteins. We have to monitor and check prior also lipid profile. We have to monitor lymphocytes, neutrophils, and hemoglobin, monitor lipid profile, check for any TB, other viruses, hepatitis B, hepatitis C, CVS, just reduced heart rate, increased PR interval, GI perforations, increased liver enzymes, that is liver enzyme derangement. So monitor LFTs and RFTs also. By RFT, it is getting excreted 30% via kidney. So organ function baseline and monitoring also we have to do. These are all adverse effects, where which investigation we have to do, what we have to monitor, what is the contraindication, pregnancy and CBC derangements, lipid profile derangement. These are all relative contraindications. Absolute, pregnancy. And we all know for every drug, hypersensitivity, absolute contraindication. Remember the channel name, TADB. Don't forget to like, share and subscribe. Thank you. Hasta la vista. Desvidania.